Hi, welcome to the Lisa Saunders Show. I'm Lisa Saunders, and I'm going to talk about a topic that's very near and dear to my heart. Many of you have heard me talk about it before on the show. It's cytomegalovirus, or congenital CMV, in my case, because my daughter was born severely infected by it. And a lot of things are happening, and I'm really excited that today I have two doctors from Yale University. They're going to tell us some of their latest research. So welcome. Welcome.
Thank you very much.
Lisa.
Thank you.
Thank you so much for coming. So just tell us who you are and what you do.
Sure. Hi, I'm Dr. Sara Ornaghi, and I am a maternal fetal medicine specialist working at the University Hospital of Milan in Italy. And there I manage high-risk pregnancies complicated by different conditions, including infection, like cytomegalovirus. I'm currently engaged in a PhD program in neuroscience with a collaborative research project between my home institution and Yale University, focused on the effects of congenital cytomegalovirus and the identification of novel treatment for pregnant mothers, infected fetuses, and infected newborns. I've worked at Yale under the mentorship of Dr. Michael Paidas for the last 2 years and a half, and we identified a potential novel treatment to fight congenital CMV, congenital cytomegalovirus.
So I was just so excited when I saw that. I have Google alerts set up for cytomegalovirus, and that popped in. And I was just telling you that I thought the guy that wrote your press release did a great job, because it was very easy for the general public to realize, oh my gosh, this is big news. So tell us what you do.
Sure.
And who you are.
And thanks again, Lisa, for
welcome.
having me. So I'm a maternal fetal medicine specialist, and I deal with pregnancy complications, blood disorders, and generally women's health. I've been at Yale for about a decade and a half. And there, I'm a professor and vice chair of obstetrics, and also director of the Maternal Fetal Medicine Fellowship, a training program for doctors that want to specialize in maternal fetal medicine. And I also direct the Women and Children's Center for Blood Disorders and Preeclampsia Advancement. I also wear a few other hats at Yale. I'm interim section chief for the section of maternal fetal medicine at Yale.
Oh, well, thank you. Again, welcome. Because some of the people in the audience won't necessarily know what we're talking about, let's just start with some basic. What is cytomegalovirus, or CMV as we generally call it?
So it turns out that CMV is a very common herpes virus. It's what we call a DNA virus. And to put it in perspective, it's a virus that would frequently cause something like the common cold or mononucleosis, for example. Most people don't have any symptoms, but on occasion you can have symptoms. The problem occurs, and when we talk about congenital CMV, that means that a fetus is being infected during the pregnancy. So that's the congenital part. So the issue about this is that women who pretty much don't know that they're infected then have the scenario set up during pregnancy where the fetus becomes infected. And why that's important is that in the US, there's about 40,000 babies born per year.
And that's a very high number. And when you say herpes, some people might think the sexual herpes. This is herpes like chickenpox, like in that general family.
General family,
right.
That's right. It's a completely different virus.
So it's a very common one.
I think extremely common.
Haven't most people had it by the time
well,
they're
you see,
40,
so that's the thing.
the...
So yes, as you get older, most people tend to have it. But the problem with CMV infection is that, one, you can have what's called a reactivation. So the virus, once you have it, you never really get rid of it altogether. It just stays dormant, doesn't bother you. And then on certain types of occasions, it can actually resurface. Or another situation that happens is that you can get infected with a different strain of the CMV virus.
That's horrible.
And why we're particularly interested in this is that, if you can believe it, it's the most common cause of deafness in this early newborn period. So, so that's why we're really focused on trying to detect it and potentially offer treatment to take care of this problem.
my daughter had the severe case where she was born with microcephaly. Like people have seen it on the news from the Zika virus, small brain.
right.
She had cerebral
Right.
palsy, severely delayed. She didn't just have a I hate to say just hearing loss, because I know a hearing loss is a shock to people. But a lot of times that is one of the main indicators, like is a hearing loss, and that's why we had that law passed in Connecticut recently that if a child fails their required newborn hearing screen, you test them for CMV to see if, okay, is that the cause? So how did you get interested in this?
Well, first, Lisa, I'm very sorry about the loss of your daughter, and it was quite devastating just reading about it and talking to you about it and hearing about it. And it's unfortunately, a somewhat common event. And so we really need to focus on this area to try to see if we can come up with a better strategy. And I will tell you in answer to your question about how I got interested in this, I have to say that over the course of my career, almost all of the projects I've gotten involved with have started in some way with a patient. It's a patient who motivated me. And that's exactly what happened in this case. Early on at Yale, I took care of a patient whose baby, what we knew in utero, was infected with CMV.
Now, how did you even know?
And so it starts out with some ultrasound findings that we thought were suspicious for infection. And then we proceeded onward to do some more invasive testing to give us some diagnostic information. And then, the therapies that are available for CMV, in pregnancy, this is a big problem.
Yes.
Outside of pregnancy, there are medications, a couple of them that we can use, and they all have some kind of toxicity. The problem is in pregnancy, we don't really have much available. In the case I'm speaking about, hyperimmune globulin has been the treatment so far and was in this past instance the way that we treat it. So we give a bunch of antibodies hoping that that would actually try to kind of calm down the infection and take care of the virus.
All right, because we're going to talk about your breakthrough that you just had, but I'd like to know what do you envision as the future of managing CMV in pregnancy?
Well, it's something that I think a lot about, and part of it is I'm hyper focused on trying to go to the next step, because one thing in science and medicine is that you have to do your homework and you have to take each step at a time and before you get to the next one. But if you were to say leap ahead and ask me what I would be looking for, I think in this age of personalized medicine, what I'd be looking for is first kind of a better screen on the maternal side, so perhaps in the maternal blood. But what's available now, if you can believe it or not, is you can identify placental cells, so that's the afterbirth, right? That's providing the nutrient supply to the fetus during pregnancy. It's also the way that the virus, typical for CMV, gets across into the fetus is through the placenta. So imagine that if you actually have a technology, for example, through a pap smear technology, and there is one available called TRIC, trophoblast isolation and retrieval, where you can actually just isolate the placental cells from a pap smear. So we can get real information about a pregnancy.
Wow.
Without having to do something really invasive, like, for example, an amniocentesis.
Right.
So that's on the diagnostic side, and perhaps that kind of modality can help us to actually sort of monitor therapy. So the way I'm thinking about, and you'll hear more about our study, is that later what will be happening, I think, is one, giving a medication or a drug to treat the infection. But then, what's got me into this is for the past 15 years or so, I've been working on what's turned out to be a neuroprotective and a neuroregenerative agent. That's called preimplantation factor, and that's a synthetic of an embryo-derived peptide, a little small protein that has some very interesting effects. So my thought would be, if you could kind of shut down the infection and then perhaps deal with the neurologic sequelae, if you find it early enough, maybe using some fancy MRI, some what we call functional MRI, to see how the fetus is doing in utero, and then provide some kind of early therapy to handle it. So that's the crystal ball.
Right.
It's not for here and now.
Because, well, I was a daycare provider when I was pregnant with Elizabeth, and nowhere in the licensing literature did it say I was at increased risk. I didn't find out till after she was born, and that moms of children in daycare, you know, when toddlers, because women are kissing them on the mouth or cleaning off their pacifier with their own mouth. So you believe in testing then, or at least certain careers?
You know, so this is a really hot topic.
It is
for
a hot
us
topic.
Right now,
so
right?
I don't know.
So let me. I'll give you my view. First, the smartest thing is to use extensive hand washing. Number one, and that good hygiene is going to cut down infection tremendously. And for women of childbearing age, people that are thinking about pregnancy or getting pregnant, what you want to do is to sort of be careful when you're handling young toddlers, right? So try to avoid, let's say,
because toddlers,
kissing.
people don't realize toddlers are often shedding it, especially if they're in a group.
In a group setting, exactly. And so daycare settings, you know, come up with that. So what you'd like to do is avoid kissing on the cheek or on your lips. And being sure that you wash your hands very well if you're changing a diaper, for example.
Or wiping a nose.
And wiping a nose, exactly, or saliva or tears. And these are simple things. They're very effective at cutting the infection.
Now, like I said, the whole reason you're here is because I saw this press release that you might, and I actually heard about this in an abstract at the Maternal Fetal Medicine in Las Vegas last year. Were either of you there?
Yes.
Was it your abstract? Or?
Sarah was presenting it.
Okay, I didn't go see it, but so a doctor outside, I was catching the, bus home or whatever to get to the plane, and I said what I'm interested in. He said, well, there's an abstract in there. Didn't you read it? And I'm like, ooh, in that big fat book? No, I didn't. So, and now you're here on my show. So please tell us what this is all about.
Sure. So the big problem and what everything got us started is that we are actually lacking an effective and safe therapy that we can give to pregnant mothers when they discover that they're infected with cytomegalovirus, to either prevent the transmission of the virus from the mother to the baby, to the unborn baby, or in case the fetus has some problems, shows some problems at the ultrasound scan, to treat that fetus in order to get the best outcome possible. We are lacking that. We don't have anything that we can use safely and effectively to treat those mothers. So we try to focus our attention on finding a drug that could kind of answer these two big problems. And we started with sort of a larger screening of different compounds, and then we narrowed it down to one drug, and which is called valnoctamide. This drug has been used for more than 20 years clinically in humans for treating mood disorders, so especially as a sedative.
Is it for epilepsy
also,
too?
Yes, exactly. And it has been shown to be safe and without any potential harms to the unborn baby. So we first started testing this drug in cells, so in in vitro experiments, to see if infected cell infected with CMV, human cells infected with CMV and treated with the drug could have a reduction in the infection. And that was what we saw. So we decided to develop a experimental model, which is using mice, newborn mice, which are infected on the day of birth with cytomegalovirus.
I read, the only thing I understood in that study, the big one that you sent me, was that the mouse is born, and that's the same level of development or something as a what?
That's correct. I mean, the brain development, the stage of brain development of a newborn mouse is similar to the development of the brain of a human fetus around the late first trimester, the beginning of the second trimester, which is the most dangerous time if you get the infection while you're pregnant, for having the transmission of the virus through the placenta to the baby and have the effects, the detrimental effects of the infection on your baby. So we decided to focus on that model because it was our main focus was essentially on the brain and the effects of cytomegalovirus on the developing brain, because that's what's the biggest complication that we can face. And we treated these mice throughout the neonatal period, so starting one day after the infection for 3 weeks. And we tested them with different tests that can tell us how the developing brain is actually doing. So we did some tests during the early neonatal period, which are kind of similar to what we do to our newborns. So what is called acquisition of neurological milestones, like flipping over or crawling, so this kind of tests. And the mice were infected with CMV and were treated with valnoctamide, essentially had similar outcomes of not infected mice.
Wow.
And we went on and we tested them also for motor functions and coordination, and that was similar. We had similar results. So infected mice treated with the drug did essentially like they were not infected. And analyzing their brains, we saw that while infection was actually reducing the ability of the brain to grow. So the brain of infected, not treated mice were smaller. There was a macrocephalic event that was not observed in infected treated mice. So it was a huge effect throughout all the aspects of neurological outcomes, and we were able to observe in this model.
I feel like I finally have hope for moms that, because my name's out there on the internet, I get people asking me questions that I can't answer, I was just tested and now I can say, well, something's hopefully coming. I always send them to a doctor, but do you know how long, because this drug, say it again,
Valnoctamide.
And you said it's not in this country, it's available in Europe, right?
Yeah, it's been available in Europe since more or less 2000, at the beginning of 2000, and then they stopped commercializing it because there was no sort of a field for commercialization of that drug. They wanted to go on with using, main pharmaceutical companies wanted to go on using other different compounds with similar effects on mood disorders and a broader spectrum of action. So they essentially focused their attention on the commercialization of just one compound, and they left out valnoctamide. Now, and that's something that happens pretty frequently, I would say, in our field, because there are huge libraries of compounds that have been tested. They've been through the initial testing, the initial phases for demonstrate that they are safe in humans, but then they are not so effective for what they were tested at the beginning, so they kind of get forgotten. But they are there, and they might be useful for something else, as the case for valnoctamide.
Well, I'm sure the pharmaceutical company that owns that will be excited to
Exactly.
So how do you go about getting this available in the United States, or finding out if it's, trying it on real people?
So that's our next step. That's what we want to focus on, how we can eventually move from these translational results from the lab, essentially all our experiments, into getting into a randomized trial to use this drug, to test this drug for prevention of the transmission of the virus from the mother who is infected during pregnancy to the unborn baby. So these are.
So what do you have to do? You get more money, or what do you need?
There's a bunch of things, and the pregnant population is one, but it's also the newborn that will benefit, and also other patients potentially, like patients that have received organ transplants, and even like patients that are immune compromised.
So you can use it for all those things.
Well, right. So it's quite a niche area, and the part that's really just novel and amazing about this is that a related compound, if you are dealing with pregnancy, you'd often would say we would not give valproic acid in pregnancy because it causes birth defects. And the interesting, really, and wonderful feature about what we're talking about with valnoctamide is that although there's just a few changes that occur in the molecule that render it safe, completely not teratogenic, so it doesn't cause birth defects. So just these minor modifications can have tremendous benefit for us. So that's another reason why we're very excited about this. But more to your point about what we need to do, well, one is we need to see if we can get a manufacturer for the drug. There's one company that we know of in Europe. And so we have to begin to make the argument that we should resurrect this compound to use. And then we start very methodically. Okay, it has a long track record for safety in terms of not causing any birth defects, so we've kind of passed that hurdle.
That's a big one, I would assume.
That's the huge one, that's the main one.
Right.
Yeah.
But then we have to look at, okay, how does the drug get metabolized? How does it work? What are what we call, in medical terms, the pharmacokinetics? So we have to have some dosing studies to understand that. And then we start, in a small way with a few patients, and then you kind of gradually build up, looking at, safety, toxicity, and then eventually what we call efficacy, which means, how does the drug perform? Does it work? Does it do what we want it to do? And then eventually you have, a large trial where you give kind of a fake medication and this, and patients that are involved don't know which one they're getting, and then you look at the eventual outcome. So, we have very good reason to think that this would be very effective. The mouse CMV is quite similar to the human CMV. And so we have every reason to believe that, it should work in the human. But one of the things I've also learned is that even though something looks so promising in the animal, you really need the clinical trial in human. And that's where we need to galvanize sort of the population that's really concerned, the CMV population, pregnant moms.
Yes.
Hey, let's get these studies done.
Yeah, the CMV community is very interested in this interview. When I pop it up on YouTube, I'll let them all know.
Great.
So, do you ever come to this? I don't know if I haven't met you, I don't think, at the CMV conferences.
I haven't made it to the CMV conference yet. We had planned to go last year, but Sara went and was able to
To the one in
attend.
Texas?
No, I went to the one in this April in Amsterdam. Congenital.
Oh, that's right. You really travel. I only go to the U.S. once.
Yeah.
So you're very international. All right. So you have a couple conferences coming up. Will you be talking about this at these conferences? I was just kind of curious what they are.
So one of them, it's what we call THSNA, and that's Thrombosis and Hemostasis Summit of North America. That's kind of a massive summit of more than a dozen societies in North and South America that are pooled together. We have a sort of a super conference every 2 years. And I'm going to be talking about perinatal stroke, which is in the brain injury field and is related in the CMV area. So I will be touching upon CMV in that conference.
And you're obviously, now in Italy, what do you do differently? Do you have more awareness in Italy? Or
I can say
what do you see the differences in our countries and how we handle it? That's what I'm kind of curious about.
About the screening for CMV in pregnancy, our guidelines says similar like American guidelines say you shouldn't screen pregnant women for cytomegalovirus because we don't have a treatment yet.
Okay.
So that's the reason, and those are our guidelines. But even those guidelines are out, there are different realities among the different regions in Italy. So, for example, you can find some, especially in the private practice, some pregnant patients get tested for CMV at the beginning of pregnancy. So what I observe is most of the time I counsel patients just on the basis of a blood exam without having anything on ultrasound scan or absolutely nothing. And this was all the thing that actually brought us to this study because I was counseling this patient, and the counseling, you cannot really tell them anything. We don't have a therapy, we don't know what to do.
Right, and it only passes the placenta 40% of the time, right? So a woman
correct.
doesn't need to be hysterical at this point just because they're positive.
Absolutely.
Now, we only have a couple minutes. What should we have talked about? If you have anything that you wish?
Sure. So first, kudos to you for getting the Connecticut law passed. And I will tell you that at Yale, we do about 4,700 deliveries per year. We've had, in 2016, 90 screen failures on the hearing test, and we've had about 2% positive of CMV. This year, we're still in 2017, and already of the 45 hearing tests that have been abnormal, we have almost 7% positive CMV detection. So this hearing testing is helpful to identify the CMV infection. So I'm happy about that. Good. I would say my messages to the community are, one, be the advocate, and please advocate for this issue with your government, both state and local. Having a voice does make a difference. We need to establish consistent funds for NIH and the Centers for Disease Control. And that happens when people really press for stable funding for maternal and child health. We're pretty much the orphans in the big picture, and we need to advocate extensively for ourselves so we can get these studies done, because without studies and without science, we're never going to get progress.
Right.
Absolutely.
Right. I mean, I just noted in Germany, for example, you're not even allowed to work in daycare if you're going to be pregnant or are pregnant. I mean, so other countries, there are some other standards until they figure out, I guess, a vaccine, or for now, it's just the knowledge vaccine at the moment, I assume. And so that is a big point. And even, I am thrilled the law passed, but even as we know, the loss of hearing from congenital CMV, it's progressive, so a child could pass that initial hearing screen, but then fail. So it's not going to catch everybody. It's just going to, but at least it catches some. And I was so excited about the people who helped get this law passed, like Dr. Brenda Balch. I mean, now we have all these materials out there that are on the website, on the Connecticut Department of Health website. Well, we're almost out of time, so I just want to thank you so much for coming.
Thank you so much, Lisa, for having us.
This is a thrill, and if you have new things, then please come back.
Absolutely.
Because, my audience knows this is my big topic that I care about. So if anything new comes out, or you have a new message to share, I would absolutely love to help you share.
It would be our pleasure. Thanks for having us.
Well, thank you so much for joining us on the Lisa Saunders Show, and I'll see you next week.